Can I have the slide, please? I think most of you know him. He's very popular with the students as well.
Introduction so that I can save those 2 minutes.
Okay, he doesn't need introduction, so okay, Shiva, you can take the stage. Thank you.
Since the topic is slightly vast, so I might take 5 minutes more. Earlier I thought it will be a parental nutrition, then I saw the title, it's enteral and parental, so I added few slides. So I'll be sticking to only the productivity of the presentation. I mean to say where, how you can emphasize and optimize the nutrition during enteral and how to maintain the parental nutrition. So Sangamitra ma'am did tell me that there is a little bit of, not much practice in parental nutrition at this part of the of our country. So try to emphasize on how to plan and how to monitor what are the concerns which are there with the parental nutrition, to focus on this aspect more. So my presentation will be more to do with the parental nutrition, little bit of enteral nutrition also I'm going to talk about it. So to begin with, I would like to say that when you opt for parental nutrition, it should not be guided by the diagnosis of the disease. For example, if someone is having acute pancreatitis, directly start with the parental nutrition. This should not be at any time kind of a decision-making process. It is a clinical condition, nutritional status, whether the patient can able to consume food, or patient has some difficulties, or the GI system is not available. These are the clinical conditions which will determine the decision of opting out for the parental nutrition, and not the decision, the diagnosis. So keep this one particular thing in mind. So India's first ever parental nutrition guidelines, which is very recently, which was published a month back, and you can refer to more details on this one regarding the use of parental nutrition in cancers. So which are those conditions which I'm going to talk about very briefly during my presentations. But if you want to know more about these things, you can refer to this paper, which is available. Even if you are following me on Facebook, the link is available. You can access this paper as well. The slides are not moving. Side arrow is also not. Thank you. So what are the barriers in cancer? Like, let us briefly understand, because we have to decide upon whether the enteral, parental or oral, or maybe a mix of kind of a choices. So the disease itself, there may be mechanical or physiological barriers for cancer patients. It may be inflammation, it may be dysphagia, it may be some certain kind of GI symptoms, and the symptoms, what you can see it on the screen, it may be more than that, what I have not been mentioned on the screen also, which may be a barrier to feeding the patient. The treatment toxic effects, like the cancer itself is such a kind of a thing where the malnutrition is induced by the disease also, and the treatment as well. So the treatment toxic effects, like of course the above mentioned conditions. In addition to that, the taste changes, xerostomia, trismus, financial problems, logistical issues, because they cannot make blood rice soup, they don't have mechanisms over there. So even that can add to the kind of condition where the optimum nutritional availability is being challenged. Along with that, the social and the family support as well. If they don't have the personals to really take care of the patients who are on enteral parental, again it is going to be having a effect on the patient's nutritional intake. Then of course the awareness, like illiteracy or the myths and the wrong advices given by many of the personals, specifically the patients who have already been diagnosed as cancer, and the patients prefer to ask those cancer patients, what did you do during your time, so that I can do the same thing. So all cancer patients are not similar, and all cancers are also not similar. This is one thing, kind of a thing you have to imbibe in your thought process whenever a cancer patients come to you. For example, all your cancer patients are not similar. Either any of the cancer patients, I would say stomach cancers, if you say all stomach cancer patients are not similar. Then comes the lack of nutrition services. During our Chennai declaration, if you have really read that paper, and we had more than 240 centers being surveyed, out of which 80 cancer institutes or the hospitals where cancer patients were seen prominently didn't have a dietitian. So you can just imagine, of all the kind of diagnosis or all kind of diseases, all chronic diseases, cancer is the most, cancer is the disease where most prominent malnutrition is being seen. However, malnutrition is existing in other diseases as well. But cancer is one where most of the patients, you can see even there are many papers who are talking about more than 80% of the patients will have malnutrition at one point or the other, either at the time of diagnosis or during the treatment. So it is such a high prevalence of malnutrition, but there are no dietitian services, no nutritional services. It's really a pity when we did this survey and we did speak about, we discussed about, and we presented during the Chennai ICNC. So this is an eye-opener kind of a thing. That's why we came out in making the fraternity aware of it, how to identify malnutrition in the most easiest way, and we recommended the self-screening tool. There are no self-screening tool. There is one in British, and it has only 3 questions, but it is not addressing all the parameters of the self-screening tool for the malnutrition. So this is the why we came out. If these 5 questions are so simple, can be translated into any of the languages. I have presented a number of times. Again, every time you have new audience as well mixing up. And please see that in your any of the institutes. If you don't want to screen the patient, you can just take a Xerox copy of it and you can stick it, translate it into your local languages, and put it across to the OPDs. Patient will read that, and they themselves will direct to your offices or your clinics. When it comes to the enteral nutrition, we all know the various types of enteral nutrition. There is nasogastric, nasojejunal, or percutaneous endoscopic gastrostomy, or maybe just a jejunostomy tube as well. Other than this, there was one more kind of a practice we at TMH we used to do, is the TEP, that is total esophageal puncture, which is no more being practiced. Our stoma will be created at the thoracic part over here, and the feed will be directly poured into the thoracic part. So that kind of a system is being no more being used. But there are some older patients who are still having that kind of a TEP, and they come to the clinic for their regular follow-up. Now comes the interesting part of patients who are on enteral feed, how to optimize. It's always, we know that it's very easy to plan 8 feeds or 9 feeds or maybe 7 feeds comprising of 2000 calories or 1800 calories and maybe 50-70 grams of protein you have planned. But the patient will he really oblige with the kind of dietary planning you have given? And always I would say more than 90% of the patients are not able to follow those 8 feed regimen. The difficulties are many. I did mention about all the barriers. Including those barriers, there are other additional barriers, like to space out these 8 feeds throughout the daytime. It's again a difficult part, because even if you are planning a enteral feed, the first feed normally starts by 7 o'clock, or some people I have seen planning at 6 o'clock. How many of your patients really start their feeds by 6 or 7 o'clock? It's very difficult, very difficult. Even if they start, there are less chances that 8 feeds will be given to the patients on a regular basis. And say, for example, how to manage this one. You have to manipulate certain things, which this one slide will actually emphasize on how to manipulate and how to emphasize and increase the optimization of the patient's enteral nutrition requirements. Homogenize nutritional strength of each feed. Very simple. 8 feeds, each feed giving 250 calories and 10 grams of protein approximately. Very easy calculation. 2000 calories, 80 grams of protein. You want to play with that, it's a little bit of alterations. You want to don't give 80 grams of protein, you want to reduce 10 grams of protein, or maybe 100 to 200 calories. Just reduce one feed of those 8 feeds. It's so easy to manipulate. And suppose if you are giving 2000 calories, in which one feed may be giving around 2-3 grams of protein. I am still seeing that many patients are still recommending fruit juices, coconut water as a feed into the enteral feed regimen. Please don't do that one, please. It is something like you're actually harming the patient, and you don't have any right. If you are less educated, forums like this, listen to us, listen to your seniors, listen to the guidelines, read guidelines, and try to imbibe all those practices. Any one feed in a day of fruit juice at the end of 1 week, can you imagine what is the loss over there? At least 70 to 80 grams of proteins you have made the patient to lose from your end. The patient has not lost from his own practices, his own regimens. It is your drawback. Just now we heard Dr. Biju saying protein is such an important and expensive and the most required kind of a nutrient, which to utilize the patient has to be active as well. So to make it that happen, you cannot compromise on the provision of proteins. Yes, calories can be manipulated. Calories are easily can be given and body can easily utilize that one. But protein is a tough task. Start the first feed of the day at the earliest. Make sure the patient, the first feed always starts by 7 o'clock. You emphasize during your counseling, whatever it may be, if you are getting at 5 o'clock also in the morning, take that first feed over there. If the first feed is given at 7 o'clock or before that, there's high chance that 8 feeds can be managed. And if the first feed is, you have planned at 7 o'clock, patient is taking at 9 o'clock, because he's getting up at 8 o'clock, freshen up, and then take a feed. Someone will make the feed for the patient, then give it to the patient. Patient may not be taking all those 8 feeds in such conditions. Avoid feeds that induce discomfort to the patient. The patient may not like or may not tolerate. It's not the allergic symptoms I'm talking about. It is the patient's intolerance. So it's not the allergic elements which are induced into the feeds. The patient is not comfortable, don't plan such kind of a feeds. Introduce nocturnal feeds. There are times, most of the patients will get up for the washroom in the middle of the night. So I do tell them that you keep a feed ready, or to make a feed, it may take not more than 2 minutes. Either you keep a feed ready and when you get up for the washroom, you can take one more feed added to over there. One feed added per day at the end of 1 week, again you are giving 1 day's entire feed extra. So you can just imagine how easy actually it is to manipulate the requirement of the patient's nutritional requirements over there. So one feed of 250 calories and 10 grams of protein at the end of 1 week, 7 days. So 1750 calories and 70 grams of protein. So easily you have provided to the patient. Use continuous drip method during intolerance. If the patient is not tolerating, always tell the patient to hand the feed and try to learn how the drip can be given to the patients. The sister also can train you, and even you should get the training for maintaining the drips, the way how many drips would comprise of 1 ml or throughout the day how much of ml a patient has to be given. You need to learn regarding these things. Encourage the patient to be mobile and self feeding. I always tell the patient, you have to make your own feed and see that no one actually has to be delegated this duty to feeding you. This itself is an act of activities which you are going to do. And we did learn from the previous presentation that the protein will be utilized if the patient is physically active. So Dr. Biju did mention rightly, don't advise the patient rest. I always say that never sleep more than 8 to 10 hours. The remaining 14 hours, you have to be physically active in some way or the other. Maybe you can climb the staircases, do some yoga, do some chorus works, go to the market and whatever it is, but see that you are physically active. Use the services of allied health multidisciplinary approaches. Take the help of physiotherapists, take the help of speech therapists. There are so many other professionals who are going to emphasize and improve upon the feeding regimen and its implications to the patient. Coming to the parenteral nutrition, I did mention this statement. Never take a decision on the medical diagnosis. That your decision is actually dependent upon the medical condition and not the medical diagnosis. Indications are many, but to simplify, when the gut is not available and when the enteral feeding is not accessible, you have to opt for parenteral nutrition. The other way of the parenteral nutrition decision is the patient is taking orally some part of it, or enterally is also feasible, but the patient has nausea, vomiting, cannot accept the adequate feeding, you can give supplemental parenteral nutrition. There are many conditions. I will just run through some of the slides which are self-explanatory. So if there is a bowel obstruction because of the tumor or maybe some other conditions where the feed is not able to move through the intestines, yes, that is one area where you should be opting out for the parenteral nutrition. Kyle's leak, the first step is not at all parenteral nutrition. Of course, you have to feed by the enteral nutrition or maybe a fat-restricted regimen can be utilized. But once if the Kyle leak goes on increasing beyond 500 ml and if it is on an increasing trend, till 1000 ml, 800 ml or 1000 ml, depending upon your institutional protocols, you can take a decision. Normally what we do is like from 500 ml till we don't opt for a parenteral nutrition, but we see from 500 ml if it is stable or not. But if it is reaching 700, 750 ml, then we start thinking about giving a parenteral nutrition. And if it is going for a 1000 ml per day of the Kyle's leak drainage, then we directly go for the parenteral nutrition. So it's an decision which is depending upon the prognosis of the patient's Kyle's leak collections. Then comes the, there are sometimes certain times where the patients have this internal bleeding as well. So during such time, of course, you are not able to make out why this condition may be existing. The medical diagnosis, the GI medicine department, normally we refer to them and they do provide us the information whether the patient's feeding can go ahead or not. If there is a bleeding, the feeding can be stopped over there. So you can always follow the Med GI's notes over there, whether the feeding has to be stopped for some time or not. Then you have these HIPEC surgeries for the abdominal cancers, which is being now widely practiced all over India as well. Even though during the process we avoid feeding the patients, but if the patient is continuously under this kind of a HIPEC treatment, parenteral nutrition can be accessed. Even enteral feed has been tried, but it is not that prominent, and it has to be given on a continuous process, and continuous observation has to be there, and the patient will more or less will be in the intensive care. So it's better that if you go on for a parenteral nutrition, the observation can be reduced over there. Even in most of the government hospitals, you don't have that much of nursing personnel to actually look after each and every patient dedicatedly. So that is why I did make this comment that parenteral nutrition can be an option over there. Short bowel syndrome, if the patient has intestinal cancers and if the patient has gone a massive resection, and during that time, yes, these patients have to be on parenteral nutrition at least for some time till the adaptation is complete and the patient can recover and enteral nutrition is being accepted, and the body is able to tolerate the enteral or the oral feed. How you can make out this whether the body is really tolerating enteral nutrition or the oral nutrition for a short bowel? The number of the diarrheal episodes, which will indicate that if there's a reduction in the episodes of the diarrhea from, maybe there are patients who are going for 24 times for the motions, which can come down to say maybe around 5 to 7 or maybe less than 10, then you can understand there's a adaptation process which is getting into completion stage, and the patient can tolerate enteral and oral feeds, and slowly in very little amount and in a very dense amount you can start feeding these patients. Then you have liver cirrhosis. Even in the higher stages, parenteral nutrition can be considered, but not in the initial stages. Anastomotic leak, if the leak is there, of course it is not again a clinical condition. Directly you can take a decision for parenteral nutrition. The medical GI will advise for the right kind of a nutritional decision can be taken by their help. The roots, we are very well aware of it. If not, if there are budding dietitians, students over into the auditorium, so you just think about it. Whenever you are planning for a parenteral nutrition, the first ever thing should come to your mind is which route we are feeding. If you are confused, or if the doctor has not yet decided whether the patient should be put on a parenteral or a enteral nutrition, and maybe there may be a weekend which is going to follow and dietitian service may not be available to you, you have to plan a peripheral, even if the central line is there. You need to understand one thing, like peripheral route is the diameter of the nerves, the veins are very smaller, central veins are the bigger ones. In a very casual way, I am putting it across to make you understand. If it's a very narrowed one, the higher viscous TPN solution may not easily pass through the veins and it may damage the vein. So that is the reason why a peripheral solution is more preferable. But if the central line is already there, or there is already a comment put on by the doctor that central line TPN has to be planned, then it's okay. If it is not been, most of the times in our centers it happens, TPN they will write, but the line they will not specify. In such cases, we try to talk to the patient doctor, which line you are going to plan it out. Is it going to be peripheral or a central? So that a right kind of a TPN can be selected. But never ever do the mistake of feeding the central solution through the peripheral. So that can actually harm the patient. So that the first ever concern of opting out for the which kind of a solution you need to be choosing for it purpose. The components, even though we call it as a total parenteral nutrition, however it's not at all total or a comprehensive, you would say. It is deficient in most of the micronutrients. There are micronutrients in each and every TPN, but they are not as per the adequacy of the patient's requirement. So that is one of the reasons where micronutrient supplementation has to be done very prominently. So this is just the difference between the central line administration of the TPN and the peripheral line administration. I'll just go through as easily as possible so that you can understand. The central is normally for a long term and peripheral is for the short term. A short term means something around 5 to 10 days of peripheral nutrition can be given, peripheral feeding can be given. If the patient is going to be on TPN for a longer period of time, the doctors are going to change the peripheral line into the central line, then thereafter you can opt for the central solution. Central line, you see, easy to meet the nutrition because they are more dense, they have more nutrients. compared to the peripheral one. So it's always a difficult part when you are planning a peripheral TPN. Meeting the protein requirement and the calorie requirement is always a tough call for that one. For that, you need to understand how to manipulate by adding amino acids or maybe the lipids to the available peripheral line. Amino acids might increase the osmolarity in marginally, but the lipids will not increase the osmolarity of the peripheral solution. So you have a leverage over there by to increase the calories and little bit of proteins. Central, you don't have to mix up any kind of a thing because you get into a very kind of a protein requirement, very kind of a caloric requirement. Higher osmolarity is acceptable in central, but a lower osmolarity in peripheral. There are little risk of nevitis in central and higher risk in peripheral. And in central may require general anesthesia, peripheral doesn't require, it can be in the ward also it can be done. Greater chances of infection in central line, peripheral there are lesser chances. Central line is a higher cost one because it needs anesthesia and a specialized nurse to really perform the procedures, even the doctors may be needed. So the central line insertion is a slightly expensive one. And the central line is a great risk of mechanical injury as well, air embolism and venous obstruction. These are the things which you are not concerned about, but you should be knowing about. The nurses are going to take care about all these complications as well. So all the guidelines do mention about the certain things. This I already made the statement which is in red. So the medical diagnosis is not the criteria, it is a clinical condition. Prior to initiating the parenteral nutrition, conduct a full evaluation of the feasibility of the using enteral nutrition. So that is one of the reasons whenever we get a reference for the patient to be put on TPN, we put the reference to the medical GI. After that, reference once we receive for the evaluation whether the enteral nutrition is feasible, possible or not. Once the med GI puts up their comment, no, you can go ahead with the TPN, then only we will plan the TPN. Till then, we don't plan the TPN. If oral enteral nutrition is less than 60% of the daily requirement of the patient, yes, I did mention in the beginning of my presentation that if it is not adequate supplemental parenteral nutrition can be thought about. If it just 10 to 20% oral or enteral nutrition is being provided, yes, total parenteral nutrition can be considered. Prior to initiating parenteral nutrition, conduct a full evaluation of the feasibility of the using EN. Reserve parenteral nutrition for clinical situations where adequate EN is not an option. And use peripheral nutrition only for the short-term purpose, as I mentioned at the beginning of these things. So the goals of the parenteral nutrition, you need to understand. We get sometimes the references by the junior residents. Start TPN to increase the weight. TPN can never increase the weight. And the patient on TPN, if he increases the weight, it is not the nutritional benefits. It may be the fluid accumulation. You have overfed the patient. So if there is something like you have to actually reduce the feeding then. Parenteral nutrition will never increase the weight of the patient. Again, I repeat, if there is an increase of the weight, it may be ascites edema, accumulation of the fluid, where the weight changes has been seen over there. Restore protein metabolism and to prevent malnutrition and improve, prevent and nutritional deficits. Your goals compared to the other method of feeding, that is enteral or oral, are slightly different from the parenteral nutrition. Counseling has to be at the beginning and you have to talk to the patient why parenteral nutrition is being given, explain the patient and relative about the TPN necessity, cost, probabilities of the TPN, how long it can be given TPN, and definitely it's a very expensive one. Focus on discouraging TPN if it is indicated due to the low food intake. Sometimes counseling can work out. And we have normally seen around 10% of the patients we reverse from TPN after the counseling. The patients do agree upon, I don't want to go for it, I can eat on my own, I will try to motivate myself, or maybe we counsel the caretaker as well. If you don't feed the patient adequately, or maybe at least till the 60% of the requirement what is required, that we normally during the recall we do talk to the relatives and we understand what is the intake and then we take a call on that one. It is governed by medical legal aspect as well, so you have to be slightly careful, but I'm not scaring you. It's very easy to maintain and it is your arena. You have to look after the parenteral nutrition along with the enteral nutrition as well. Take advice from the medical GI department for advice on necessity of the TPN as well. Don't ever get scared to talk to the doctors. They are always there to help you out. It is our reservations. We are restricting ourselves for not communicating, and they are not harming you. They are not going to shouting at you. They are there to guide you for the purpose. It is our community which has resisted from ourselves because maybe our predecessors never taught us how to communicate with the doctors, on what terms and what conditions we need to speak to them. So talk to them and you will also learn many of the things from when you discuss the matters with the doctors. How to calculate? First thing you have to understand what is the input and output. Have an habit of reading the papers over there, the clinical notes, what has been the input, what has been output. If you initially don't understand, talk to the nurses, they will guide you what is the input and what is the output. Normally what we do, if input and output is normally the same, there is no fluid accumulation. If input is more and output is less and the difference is more than 500 ml, it means that fluid accumulation is there. So that gives you an idea of opting for a TPN solution which has a lesser volume. So you have an hint given to you. There are various formulations. Some TPN come in lesser volume, some come in higher volume, some come in very high protein, some come in very high calories. Some TPNs are having lot of dextrose and some TPNs have lesser dextrose. So if you want to, if the patient is a diabetic or hyperglycemia is persistently seen, you have to manipulate the dextrose content of the TPN as well. Either you have to feed slowly or you have to opt for a TPN solution which has lesser dextrose in that. Look out for the purpose and indication. I did mention about sometimes the counseling works out and you don't have to give the TPN as well. So the indication, you can talk to the doctor and why you would like to give the TPN, try to understand the decision making process, and maybe if your role can reverse the decision, it's well and good for the patient as well. And duration of the TPN also, you should be knowing how far it is going to be fed. Fluid calculations, the weight into 30 ml. It is the general requirement of the fluid volume. There are no actual recommendations or guidelines. What is the fluid requirement of a patient? Either a healthier one, or maybe patient who is under treatment, or the patient on EN or PN. So to have your calculations at ready, 30 ml into the body weight. Now this is your standard benchmark. If there is a fluid accumulation, you can go on reducing from 30 to 25. And if there is no fluid recommendation, and if the patient is of a higher weight, you have a leverage of giving a higher volume TPN. Protein, yes, the way you calculate for the EN or the oral feeds, if you are considering at least 1.2 or 1.5 grams of protein, you can go ahead and calculate accordingly, and if the proteins are falling short of, try to add amino acids for to the solutions. Before starting TPN, what you need to do is that understand the baseline weight, always take the weight, so that you know whenever concurrently you are going to weigh the patient, where if there is a fluid accumulation, there will be a weight changes, you can see. That is a weight increase. Baseline lab values, the sugars and even the LFTs you have to follow, because TPN is going to induce some kind of elevation in the LFTs which may harm the liver functioning as well. So you need to be careful in understanding the LFTs, and if it is persistently increasing, talk to the medical GI people whether to stop the TPN at what juncture and how long it can be. Monitor blood sugars, inspect central venous access site, that can be infection. This is the nurses who are going to do this one. Patient should be afebrile, there should not be any fever. WBC and check for dehydration, check for hemodynamical stability. So the last point has to become the first. Before starting the feeding, the patient should not be a candidate of the refeeding syndrome. How you can identify a patient can be a candidate of refeeding syndrome is, the best thing is you can just ask the relative or the patient when did the last time they had a full meal or maybe adequate nutrition was being consumed. Normally this patient, they don't consume for the last 2-3 days. That is why the TPN has been decided upon. But if they are consuming at least 50% of the daily requirement, you don't have to really worry about the refeeding syndrome. But in cancer, most of the patients are being starved for many days. That is why we are opting for the TPN. So if you are in doubt, so it's better that you try to check and correct the electrolytes and thiamine, and then slowly start feeding the patients. But if you are having the doubt the patient can be of a candidate of refeeding syndrome, better to go slowly for the first 12 hours, see any kind of a discomfort of the patient, and maybe escalate for the next 12 hours, so that within the 24 hours you can come to know. However, having made this statement, I would make it very clear, refeeding syndrome can happen even after 24 hours. From 48 to 72 hours also the symptoms can be seen. So, but you have to be a close observer for this. If TPN is refrigerated, remove and bring it to the normal room temperature. Last 2 more slides, I think I'll finish off. Change IV administration set for after every 72 hours. If 3-in-1 bag is administered, change IV administration set for every 24 hours. Whenever the bag is being opened up and mixed up, the lifespan of that bag is 24 hours. Beyond that, don't try to take I have seen in private hospitals, the private clinics, the bags goes on for more than 30 hours. That is not the right way to feed the patient. If one incident of an infection can spoil the patient treatment completely. Use open tiffin bag for maximum 24 hours. Partial parenteral nutrition can be given during the night as well. If the patient is having some kind of a good feed, either orally or parenterally, so give the TPN during the night time so that the patient can be mobile throughout the daytime as well. And patient is relieved of that, hanging back throughout the 24 hours. No need of time gap. Time gap should be given between two bags as well. If you are going to feed the patient adequately for 24 hours, there was a concept of giving 2 to 4 hours gap between two feeding bags. It is not at all required. There is no need of giving rest or something. The body, the veins doesn't need rest. They are always working from the time of your birth till your die. They are always working. So you don't have to really give a rest for the veins so that again you can start a fresh feeding bag. The bag when started, the time and date should be noted on it should be labeled properly, and every 4 to 6 hours the patient should be mobilized to the best of his and her ability. If required, take the help of the physiotherapist. I did mention about if you are giving protein, it has to be utilized, the patient has to be mobile. TPN bag observance, check the expiry date, check for the decoloration, check for curdling kind of a thing. Disposal of the discarded TPN should be followed by the medical disposal protocols. And the nutrient precautions, every TPN bag add 10 ml of MEI and micronutrients at least twice a day. If the patient is severely malnourished, maybe every alternate day can be given. I have come across people giving everyday micronutrient supplementation as well. It is the clinics or is their expertise protocol, the way they are supplementing the micronutrients. Iron can be decided with the discussion of the treating doctor. And the monitoring now. You have planned and you have taken the concerns of the pre-planning. What are the things what you need to be monitoring? Patient stability, breathlessness or shivering or allergic reactions. This can be exhibited by the patient and they can refer it to the nurse also, and when you go for the follow-ups you can also notify. Patient should be afebrile. Micronutrient deficiency is normally being seen even in elderly people, so you have to talk to the doctors regarding the supplementation of the vitamin D, and CBC, WBC has to be monitored continuously. Accumulation of water, I did mention about the fluid accumulation. Weigh every 3 days so that you will understand whether ascites and edema is being setting. Random check of infusion rate, blood sugar every 6 hours, blood pressure as per the institute's protocol, lipid profile every week or as per institute protocol, and hepatomegaly if the patient is on a long-term feed, the gallbladder sludge might form, gallbladder stones can form, and there may be chances that the liver get harmed. So that is why the LFTs have to be monitored very regularly. So the monitoring of the TPN and the daily monitoring, when you go see that electrolytes, blood sugars, fluid balance, body weight, vital signs are available. Laboratory testings like LFTs, I did mention about kidney functioning. Rarely you need to do this one. Serum triglycerides, pre-albumin and albumin. Pre-albumin normally we don't do, but albumin you can have a follow-up of that one. And serum protein trace elements as well. Adverse effects can happen very rarely. It depends upon the nursing calibrations and the nursing skills. Look out for hyperglycemia or catheter-related bloodstream infections, central vein thrombosis, TPN-associated liver diseases, refeeding syndrome I spoke about, negative effect of adaptive immunity, and TPN-supplemented glutamine, which can improve the immunity as well. If the patient is a candidate of infection or you feel there is an infection setting, glutamine can be added to the TPN. These are certain complications. Actually, during my narration, I have mentioned, I don't want to repeat to save the time. If you need the presentation, you can ask for from the organizers as well. So, the subcutaneous is a very latest kind of TPN which is into the research aspect. Now, I did mention about infusion throughout 24 hours or maybe a partial nutrition. But this kind of a nutrition which is known as a subcutaneous parenteral nutrition, which will be as a kind of a dose which can be given as an injection over a period of just 1 minute or maybe a 30-40 seconds, and the TPN has been administered. However, to get into this practice, it might take maybe a decade or maybe at least 5 years into India, but this is a new thing which is going to come up. You don't have to give the entire TPN for 24 hours. So this is a game changer for the kind of the way we feed the patients. And you can see why the physical activity is required, and you know Paul Mishmer, when he was on TPN, when he underwent the surgeries, he was consistently doing exercise even when he was on TPN. So that is why whenever you are recommending TPN or you are planning a TPN and monitoring the patient, never ever forget, whenever there is an opportunity to get into the physical activities, encourage and counsel the patient accordingly. Thank you so much, and sorry really I took more time because
not at all, Shiva. Thank you for explaining so beautifully.